McBride, and I am your professor in 160, NUR160. Because of the Martin Luther King birthday celebration on Monday, we are not having class, and this is a recorded lecture for you to have access to the notes and access to the information that you're going to not be given today because we're not open. So the goal here is for you to make sure that you join, that you review this information. I will be putting this on the Evolve videos for NUR160, so check that out if you for some reason need to review this again, or for some reason you don't have time for whatever reason. Make sure that you do review this sometime over this weekend before your next class. Remember that some of this information may end up being on your quiz that we're having this week. I apologize that sometimes we assign reading and then your quiz will then form that information and we'll be following it at that time. So here we go. Again, we're going to be talking surgical patients. We're going to discuss the reasons for performing surgery. And I've worked in surgery for many years. I enjoyed it. We're going to identify potential risk factors for complications of surgery. We're going to explain the nurse's role in the various phases of perioperative nursing, illustrate how robotic surgery has shortened recovery time, compare the types of anesthesia used for surgery, verify the safety measures in place to prevent errors regarding surgical site as part of the National Patient Safety Goals, and assist the patient with psychological preparation for surgery. We're going to state the nurse's role during the signing of a surgical consent. What is your role when obtaining the consent? Of course, we don't obtain it, but we may have to witness it and witness the patient signing. The physician or surgeon should be explaining the procedure, et cetera, et cetera. We're going to compare the roles of the scrub person and the circulating nurse. I've served both of those roles, and select interventions to prevent each of the potential post-operative complications. In clinical practice, we're going to perform perioperative patient education for the patient and the family, implement physical preparation of the patient before surgery, prepare to perform an immediate post-op assessment when a patient returns to the nursing unit. Now, there are some LPNs that are working in post-op these days, as well as in small clinical sites where they're doing some type of procedure like at eye clinics, orthopedic clinics, etc. We're going to need to be able to assess adequate ventilation of the lungs and note that the patient is actually recovering from the anesthesia, assess for postoperative pain, provide comfort measures, promote early ambulation, and return to independence and activities of daily living, and then, of course, perform discharge patient education and documenting that discharge information and for what they should be doing when they're at home. Okay. So, it's a lot to cover. So, surgical patients, what are the reasons for surgery? First of all, let's define surgery. It's the branch of medicine that employs operations in the treatment of disease and or injury. Surgery can involve cutting, abrading, suturing, or otherwise physically changing a body tissue or organs from their original appearance, or trying to return those body tissues to their previous appearance if necessary, as in plastic surgery. A procedure may be elective, meaning we decided we wanted to do this. This is voluntary, such as when a hernia repair is scheduled in a week away or a couple of weeks away. Emergency surgery is often necessary in trauma cases in which serious consequences will occur if the person does not have surgery. Palliative surgery is to relieve pain or complications. It's performed to make a patient more comfortable. We may do palliative care for cancer patients by reducing the cancer or the tumor that's pressing on different parts of the body It's not for cure, it's again for comfort or for pain relief. We may remove a metastatic tumor from the abdomen that is causing considerable pain. That's another form of palliative. Diagnostic surgery, as a biopsy of a mass, is done to provide data for diagnosis of the problem. And then, of course, reconstructive surgery, such as mammoplasty after mastectomy, is done to restore the appearance or function. Curative surgery alleviates or cures a problem, as when gallbladder surgery is done because they have lots of gallstones, or when they remove a stone from the kidney or the ureter in order to alleviate pain. All surgeries have an element of risk, so that the patient must know the risks and what the benefits of surgery, and if there's alternative treatments. That is called a informed consent. So the reasons for surgery. A procedure may be, again, elective or voluntary, or it may be emergent. Removing that metastatic tumor from the abdomen that is causing pain may be the reason why we're doing that again. Or it may be because we're restoring the appearance. Patients at higher risk for surgical complications, such as the infant or the older adult, they may have higher possibilities of having a decline in function during surgery or after surgery, maybe having higher incidence of infection, etc. It may be difficult for us to keep the core body temperature as in older people as well as young people. And then, of course, our young and old also have a problem with maintaining fluid balance, so they may have possible problems with fluid balance. Other types of patients who are at high risk during and after surgery are those with bleeding disorders, cancer, heart disease, chronic respiratory disease, diabetes, liver disease, immune disorders, chronic pain patients, upper respiratory tract infection may be realized, and they may have fever. And those patients with drug abuse also have some issues with their respiratory and cardiac systems. All patients are at risk for surgical site infections, so adhering to the guidelines for surgical site care and making sure that certain that we're using the appropriate chemicals to help lower the amount of bacteria, the amount of things on the skin is very important, and it's ongoing that we monitor for signs of infection while the patient is healing. There is also a possibility that during surgery, allergic reactions may pop up. A patient can experience allergic reactions during any type of perioperative period, and it can be life-threatening. If they have an allergy to agents such as the chlorhexidine, which is used to clean the wound site, or if they have an allergy to iodine, we need to know that so that we can choose a different product to use. Our management strategies include early recognition and essential recognition of those allergies to ensure patient safety and improved outcomes. Again, one of our national patient safety goals is to increase safety during the operative process. And that also includes early recognition of complications, as well as making certain that we're doing surgery on the correct body part or the correct area. The National Institutes of Health has a number of articles on perioperative allergies and complications. The British Journal of Anesthesia also has shown the different types of allergies and problems that occur with surgery. So definitely take a look how important it is that anesthesiologists or anesthetists and allergists have a key to planning future anesthesia. So those patients need to let us know if they have lots of allergies or environmental allergies. When a suspected allergy does occur, then we're going to make certain that we provide timely referral, timely treatment in order to help cut down on the allergic response. Numerous factors affect the person's ability to tolerate surgery. Again, infants and older adults are at high risk for surgical complication because of their immune system and decline of their various body systems. And we need to make certain that we're maintaining their core temperature. We're going to be, as part of the anesthesiologist's duty, is to maintain that. We usually use a bear hugger or some type of heating if we know that the patient is going to be in a very cold climate. We also want to make sure that we're giving fluids and that we're monitoring for dehydration and overhydration. We don't want to give them overgive fluids, because then we would cause issues with their breathing again. We want to monitor the cardiovascular system, the respiratory and renal, integumentary, neurologic, and metabolic systems. And there are some patients who are at higher risk because they have cancer or heart disease or problems with their respiratory. Of course, our diabetics and those patients with liver disease also have a higher autoimmune issues, so that they will be ones that would develop an infection more easily. So we're going to be watching those patients much more clearly. If you review Williams, page 750, table 37.1, they're going to go over the greatest risks there are and how this all comes to play. So if you need to go back and refer to that. For the older adult, one of the greatest fears is facing surgery and the loss of independence that may occur after they have surgery. They will be wanting to know, when are they going to be able to recuperate? How are they going to recuperate? Who's going to take care of them? Are they going to need to go to a nursing home for TCU, which transitional care, or are they going to have someone to be able to come in to help them when they're at home? Of course, that could be almost anyone's concern these days. Optimal perioperative management of the geriatric patient. We're talking the perioperative management. Perioperative is before, or preoperative is the assessment we do before they even come into surgery. We start planning for discharge for these patients as soon as we know they're having surgery. So when they're in the doctor's office and they're talking about having surgery, we're already planning, okay, what are they going to do after surgery? Who's going to be there to take care of them? Are they going to need to go to a SNP, TCU? How long are they going to remain in the hospital, etc.? So with our preoperative assessment, we're going to make sure that we know all about their disorders, what their comorbidities are, who's in the home, what type of family support do they have, what type of knowledge or background. Just because a person might be a nurse or they might be a doctor, it doesn't automatically make them the perfect candidate for sending home early if they're not ready for that care, or if they're not capable of taking care of them. Patients are going to want to know about the anesthetic techniques, so they're going to talk to the anesthetist. Very important, especially if you have hyperemesis after anesthesia, to discuss how are you going to manage my feelings of nausea after surgery, because clearing out those meds after surgery sometimes takes a little while. It can cause a lot of patients to have nausea, vomiting, inability to keep foods and fluids down, so that impairs their return to full operation. So that's very concerning. The anesthesiologist should explain all about the procedure, what their plan is, and he should discuss that and allow them to also say, well, this is what has happened to me in the past when I've had surgery, or this is what has happened with my family members, because the doctor needs to know if family members have had issues with anesthetics. And that's part of medication management and safety. With the medication management, we need to know every medication the patient is on, all of their over-the-counters, any herbals, and any response or relationship to any issues they may have had. Then our patient counseling is going to also look at counseling them for how are they going to take care of themselves, what meds are they going to be using afterwards, what things do they need to avoid in the home, and then we're going to also do a fragility screening, which is identifying those patients who are frail that may need further assistance or further support. Again, those are the patients that we sometimes send to TCU because going from the hospital to home is not actually an option. So perioperative risk, what is the additional risk factors for surgery? So we have what is the timing of the surgery, type of surgery, functional capacity of the person, and then their clinical risk. If you have diabetes or other chronic diseases, those conditions themselves will lend to some issues. With the stress of surgery, it may cause swings in blood glucose levels. As we know, when a person is under stress, the adrenal glands kick in, cortisol is released with stress, so blood sugar levels go up. That may make the patient have to have more insulin or less insulin. So we're going to be telling them how to take care of their blood sugar needs before surgery, that they need to, of course, make sure that we know when they took their last insulin, how much insulin, when did they last eat. Insulin and blood sugar also has wound healing delays. So that patient with diabetes may not heal as quickly. It makes the risk of dehiscence greater, which is these, we've got them all sutured up, they have an abdominal wound and they dehisce. That means that that suture line broke open and now they have tissue that is protruding from that surgical line. And we'll talk more about that in lab when we go over wound and wound care. There is a higher incidence of infection for those patients that have autoimmune diseases. Liver and kidney disease make it more difficult to metabolize and eliminate anesthetics, therefore they can stay in the system for much, much longer. As we age, healing is slower, as well as medication clearance. There again, medications do build up, so we have to watch that. The very young infants have difficulty controlling temp. Their hypothalamus is not as matured, and they don't have as much fat sometimes, and they aren't able to hold on to that heat. They also suffer anemia much more quickly because their blood volume is so much lower. So they are at risk of having anemia or having blood loss, and are also at risk of dehydration because of fluid levels. Malnutrition. Inadequate nutritional stores can lead to poor wound healing and skin breakdown. So we want to make sure that our patients have good wound healing. So we make certain that they eat well before, if they're planning to have surgery. As sometimes we have to have patients actually lose weight a little bit before they have a knee surgery or a hip surgery. Want to keep them well hydrated, but we also tell them to be NPO after midnight, or we tell them to don't eat anything or drink anything after 10 p.m. But we need to make sure that they are getting their volume before that so they won't be low on their volume, and also to make sure to check their electrolyte values, because dehydration is going to make those values change. Dehydrated patients are at risk for problems with pressure areas during surgery. So we have to make certain that we're padding any type of pressure areas on their skin wherever they're dependent. Obesity also lends to having more difficulty for breathing. A patient that is very obese is going to have a problem with hypostatic pneumonia, meaning that they have a higher incidence of having pneumonia develop because of low oxygen and expansion of their lung system. So they're not going to clear out fluids as easily. Excessive fatty tissue also is a factor in poor wound healing. Patients with hypertension, left ventricular hypertrophy, cardiac arrhythmias, or other heart failure are at risk for myocardial infarction or heart attacks from the stresses of surgery. So we definitely want to have them screened for any heart issues before they have surgery. Also, peripheral vascular disease or poor circulation can also predispose the patient to clot formation or thrombus formation. And so we want to make certain that that we're going to put anti-embolism stockings on them during surgery, and then that they wear them after surgery until they start walking or getting around. We may use some SCDs, which is those compression devices that move fluid and blood through the legs with compression of air. If they have a substance use disorder or alcohol use disorder, we need to know about their liver. How is their liver doing? Because it takes that liver to get rid of those metabolites of the anesthetics. We also have an issue with if they have alcohol, they may have withdrawal symptoms during surgery. So we want to watch for any type of adverse blood pressure, spikes, etc. Smoking causes increased lung secretions from anesthesia, and that also predisposes that patient to atelectasis and pneumonia. So we tell our smokers, try to cut down. They're also at a higher risk for blood clots, DVTs, PEs, etc. If patients are taking aspirins and anticoagulants, they're also at risk for excessive bleeding. Corticosteroids also reduce the body's reaction to fight off infection and also delay the healing time. And of course, fear. Fear stimulates the sympathetic nervous system and causes the release of hormones, causing swings in the body's chemistry and vital signs. It can make the muscle tension more. It can cause interfere with the desired state of anesthetic. So we don't want that patient. We want them to be as calm as possible. So that's very important. So preoperative phase, we have the preoperative phase, the perioperative phase. So preoperative is the testing we do before surgery. It depends on the institution's policy, but we probably will send those patients in to the clinic at the hospital if that's where they're having their surgery. And while they're there, they'll do a urinalysis, they'll do a complete blood cell count, they'll look at their blood chemistry, they may do an EEG or EKG to check their heart rhythm. They'll want to know about their electrolytes, sodium, potassium, etc. And if they're on, whether they're on blood thinners or not, they may do a PT-INR or a PTT to check their blood coagulation issues, if there are any. And they'll also do a type and cross match if they think that there's going to be or think about or tell the patient we're going to do a type so that we can get your blood type for surgery if we think we might need blood products. They may wait for that type and cross match until the day of surgery to get that. So it just depends on what the doctor thinks is important. If they have a difficult blood type or had problems getting a good match, we might want to go ahead and do a little bit of that before surgery. Perioperative nursing care refers to the care of the patient from the time of the decision to have surgery through recovery. So it's the entire time. Preoperative is from the very before surgery to postoperative care. Surgery may be performed as the same day, may be done outpatient. It can be done in outpatient setting clinic. It can be done inpatient in a hospital or surgery center. Minor surgery, I always say, we talk about minor surgery. I always say minor surgery is any surgery being done on anybody else but me. But minor surgery is often performed in a physician's office. Patients having same-day surgery are admitted and discharged on the same day, and the prep for surgery begins prior to admission again. We start planning on discharge as soon as we get them set up for surgery. Diagnostic tests are done days before the scheduled surgery so that it can guide the plan of the surgery. Patients' education for postoperative care must be done efficiently because these days we have such short stays in the hospital. Double mastectomies are being done, and those patients are sometimes going home the same day. They're going home later that evening or by the next morning. Total knees that used to be in the hospital for 3 or 4 days are no longer being there that long. They might be lucky to be there for 30 hours. You have surgery in the morning, then you're gone the next day sometime. So length of stay is really reduced. So we need to be very efficient in how we deliver education. The patient needs to be a part of that plan. We need to make certain that the family is involved and that they know what they're going to do when they get home, or who's going to take care of them. How are they going to get meals? Who's going to help them in the bathroom? Are they going to need someone to help them get cleaned up or take a shower? Here again, review these phases of surgery. Sometimes we do have questions on the exams about what is the preoperative phase? When does discharge start? Again, in the doctor's office, right when surgery is planned. So make sure you know that. Postoperative is after the surgery has been done. Okay, surgery, preoperative phase, thorough health assessment. We've talked a lot about that. We're going to need a baseline. We're going to need a baseline of their medications, a baseline of their vital signs, a baseline of any of their blood work, and any accurate health. We need an accurate height and an accurate weight for figuring out what type of anesthetic agents are going to be given. They use their height and weight to do weight-based meds, so that we don't overgive or undergive for their body. It is a lot of math that has to go into that. So if you don't like math, don't become a nurse anesthetist because there's a lot that goes into the being very safe with that. General goals for all preoperative patients are the same, that the patient will be prepared for surgery, physically and emotional, that they'll be able to demonstrate deep breathing, coughing, and leg exercise to minimize complications, and able to verbalize understanding of the procedure and the expectations of them during the postoperative period, able to maintain fluid and electrolyte balance throughout the perioperative period. So that's a lot of goals right there. So we have this patient, they're in the preoperative procedure. Care of the surgical patient is divided into 4 phases: preoperative, intraoperative, post-anesthetic, immediate care, and then post-operative care. So we have 4. Again, those are pre-op, intra-op, post-anesthetic, immediate care, and then the post-op care. During the preoperative phase, patients that are low on their blood, let's say they're very anemic, or they need to be scheduled to have, make sure that they can have family members or somebody donate for them. They could make sure if they have a difficult blood type, they need to go ahead and have a type done, and then make sure that the blood bank has their blood type available if they think they're going to need blood. For those patients that are not anemic, they may actually donate 2 to 4 weeks ahead of time before surgery, and that blood can be banked in case they need blood so they can get it from themselves instead of taking someone else's blood. So that would eliminate the possibility of transfusion issues, and as well as contaminated blood or bloodborne viruses such as HIV or hepatitis B or C. During the surgical consent, the form must be signed before surgery, before the patient has had any medications. Once the patient has had medications, that is not an informed consent, that's impaired. It is a legal form, so it must be completed in ink with the correct spelling of the procedure to be done. The surgeon is responsible for obtaining an informed consent, and then he needs to make certain it's clear every possibility of every alternative procedure or possibility they may have to change over to an open if they're doing it laparoscopically, so that the patient is fully aware that this could change. If they still have questions and that physician has left the room, bring the physician back, because definitely they need to get that clarified. They need to have a full and informed consent. The surgeon often explains the procedure while the nurse is still standing present, which is good, because then you can hear, and then if it's just a few words that the patient may not have understood, you can simplify that for them if you need to. They will then ask the nurse to obtain the patient's signature on the form. If the patient does not understand the procedure, and again, don't have them sign it. Make sure that they get back in there to explain things, because we want to make sure that they understand. If the patient is a minor, confused, or mentally incompetent, then another person or party, such as a parent, guardians, or spouse, they need to be present for that explanation, and because they will be the ones signing the consent. The signature of the responsible party must be witnessed by another party, often that's a staff member. The consent form must show the procedure to be performed and the risks involved. It must include the time and date, and again, signed in ink, and a witness is going to be needed then if they are there. If the patient is unable to sign, or they understand that they're incapable and X is acceptable as long as it's also witnessed and if it's allowed by the institutional policy. If emergency surgery is needed and the patient is not conscious, again, or able to get consent, and immediate family is phone contacted, then telephone permission can be given, but there must be two witnesses on that extension to hear that family member to give that permission. If this is life-threatening and that patient is not aware, is comatose, and they're going to die otherwise, then they can do surgery without the consent and get the consent later. So that's always good. All responsible adults are asked to complete advance directives when admitted to the hospital. If they do not or already have such a document on file, then they should have that, and the doctor should know about what's in that advance directive. There is a lot of information about informed consent. I would reread that area over. Know what the LPN and what the RN can and cannot do, and what would put you at risk. Also, understand informed consent. It means the patient is aware of their risks, benefits, and alternatives to surgery, and understands. Sometimes they'll sign anything, so make sure that they do understand. Okay. All right. We're going to document in the medical record that yes, that patient signed the consent and that we have it on board. Let's see here. National patient safety goals. Let's go back to this. National patient safety goals, again, that's our double identifier. That's using the name and the patient's ID, but it also includes having the universal safety protocol as part of our surgery. So we do a universal protocol, which is a timeout. It has three parts basically. Pre-procedure verification process that the patient is the correct person and that they have met all their needs, that the consent is completely informed, that they know what's going to be done. Then the other part of that is making sure that they have the right procedure site, meaning if it's a left leg, third toe, distal part of the toe that we're doing, that they have identified that and they're able to participate in that. The third part of that is performing the timeout before the procedure, before surgery commences. A timeout is called, and the correct patient, correct site, and correct body part are all, again, verified, and they are asking to make sure that they have all the equipment, all of the meds, all of the drugs, any blood or anything else that they're needing for that patient. Okay, we're done with that. Let's talk about medications. Reglan is a medication that is given to a patient before surgery. Why would this be given prior to surgery? Does anyone have any thoughts think about that? Because again, I can't get your answers. You can send your answer to me telepathically. I might be able to pick it up. Okay. Think about that. If you have a chance, you want to look up Reglan. You want to write this drug down because it may be on a test. Reglan helps with nausea and vomiting by speeding up the emptying of the stomach. Now, it doesn't treat nausea and vomiting. What it does is it makes certain that that stomach is empty. That way, we don't have to worry about that patient regurgitating anything from the stomach. We don't have to worry about them getting that into their lungs. We have to monitor diabetic patients for hypoglycemia because food absorption can be decreased. So their insulin may need to be adjusted. It does have a set of sedating effect, so we need to monitor for the patient for oversedation. So the question is, what is one of the side effects with Reglan? It could be it's oversedating or a sedating effect. It does have cause drowsiness, fatigue, lethargy, dizziness. It's because it is a histamine-based medication, and that's the reason why. They may have a feeling of restlessness. That's the adverse effect. Sometimes it can have opposite effect. and cause a desire to move. So repetitive involuntary muscle contractions, including eye spasms, blinking, twisting of the head, protruding of the tongue may occur. Surgical safety, here's a surgical safety list and then a YouTube video for you to watch. I'm hoping that we could get this here to share here, so we'll see. And I'm going to see if I can get this over here to you. There we go. I'm hoping you'll be able to also hear this. So this is the WHO surgical safety list. Next is going to be the timeout. And this is the sign out after surgery. And that is it for surgery. As it's done over in England, it's done very much the same way here in the United States. So if you ever get a chance to go to surgery and see the timeout, again, we do timeouts also on the floor, but we want to make certain that they're done every time that we're doing any type of procedure, and including the patient when they're awake. When they're not, then we uh, make sure that the team or the physicians and everybody's on board with the same thoughts and same plan. So again, discharge planning should begin when? Well, if you said pre-op or at the surgeon's office, then you are correct. So patient teaching. Patient teaching is before surgery, helps reduce. Does it the patient's anxiety schedule with fear of the unknown, the amount and type of anesthetic needed, post-surgical pain, corticosteroid production. So Again, we want to make sure that we do a lot of patient teaching to help reduce their anxiety, help them to, again, help them know what is the proper anesthetics and their corticosteroid production. If they are on steroids or prednisone, that can also reduce the stress on the body. Patient teaching, again, what to teach, and for the informed consent, the patient must give permission. We're going to repeat this. I think they're hitting this pretty hard, is to make certain that we're doing good informed consent. Again, the surgeon will explain the risks involved, the benefits, and any alternatives and the consequences if they don't do the surgery. The nurse frequently acts as the witness to the form and can sign as a witness. What happens if the patient is unable to sign consent? Again, remember those things that we recover. If a patient cannot sign or is not competent to sign, then a family member or guardian can. If they're comatose and unable to sign, it's emergent, then we can go ahead and do surgery and get signature later, or we try to get a telephone consent. If we get a telephone consent with family members, we need two witnesses on the phone and then to sign that we heard, yes, they are okay, that everything was explained and that they understood and they had and that all their questions were answered. What topics should be included in patient teaching? Let's think about that for just a moment. I'm actually going to slide my slide over so that you can see this, because I think it's important for you to see the notes on this. So here we go. They should be taught NPO status, what it means and why, that they're going to be given intravenous fluids, that we need to prep their GI system to make sure that if they need laxatives or if they need colace for stool softening, that it's done before, because again, remember that they're going to be getting a lot of narcotics for medications for pain, and some of those anesthetics are also very constipating. So we need to make sure the patient is ready for that. If they have any skin preparation they need to do, when I had total knee surgery, they made me wash completely with the chlorhexidine at home. And then, of course, the day of surgery, they had me wash my knee once again, not to shave, not to do anything like that. We need to make certain that the patient doesn't have a latex allergy, that they have good respiration, that they're able to breathe well, that they can follow. We teach them the incentive spirometry ahead of time and why it's important. Make sure they have that device as soon as they get out of surgery so they can start doing that. We need to consider cardiovascular. Do they have heart issues? Do we need to be concerned? Urinary considerations. Are they going to have a Foley? Will the Foley be removed, or are they going to have it after surgery? Pain control. Will they have a patient-controlled anesthetic pump? Will they need to be told how to use that to press the button when they need to have anesthetic? And we also need to make certain that the patient's family knows not to play around with that machine, that it would be dangerous for them if they overgive that patient medication. We don't want them to do that. Again, we're going to be giving them certain meds. And again, I'm going to pull this over so you can see these because it's a long list. They may need to be taught about Ativan, Valium, Versed, morphine, Zantac, Zofran, Ansef, Solumedrol, heparin, or Coumadin as blood thinners. Change Coumadin to warfarin because warfarin is the medication that we call it now. All medications can be held except for those needed for long-term conditions like Dilatin and lisinopril. So we want to, if they have warfarin, if they're on warfarin, they may be told to stop that 2 to 3 days ahead. We're going to tell them not to take any NSAIDs because they thin the blood too much, that we don't want them taking aspirins. Remember what your NSAIDs are. If you need to, and you still don't know these, make sure you're getting them written down because I'm not going to give them to you today. I want you to look those up and have a card or have them in where you can immediately spill out the 7 or 8 drugs that are considered as non-steroidal anti-inflammatories. You need to know those by now. Okay, let's go on, see what else we have here. Coumadin versus, or warfarin versus heparin. I'm going to say warfarin versus heparin, okay? Heparin is sub-Q. That is, warfarin, on the other hand, or Coumadin, is a pill. Coumadin, or warfarin, it's best to give in the evening. We're going to check their PT and INR, and usually they correct the dosing or things when they do blood work in the afternoon, and then they'll change their dose that evening. So it's better for them to take that in the evening and be consistent with that. Their PT and the PT's normal, make sure you know this, underline it, circle it, highlight it, is 11 to 14 seconds. Yes, that's a question that's going to be on one of your tests one of these days. The INR should be less than 1.1. That's in healthy people. But if they're taking Coumadin, they're going to have a goal. They're going to have a goal of 2 to 3, depending on why they're taking their warfarin. If it's for valvular disease or AFib, they may be taking that, and they may have a goal that they need to keep their warfarin between their INR between 2 and 3. What is the antidote for Coumadin? Now, I want you to write this down. We've got warfarin, and again, spell this warfarin, warfarin, warfarin. Okay, your antidote for warfarin is vitamin K. Your antidote for heparin is protamine sulfate. Now, your 3 medications that are sub-Q again are heparin, Lovenox, and insulin. Coumadin is oral, so it is not, or warfarin is oral, it's not given to that, okay? Okay, what is the action of warfarin? It decreases the production of vitamin K-dependent clotting factors, and you have multiple of these, and it happens to be 2, 7, 9, and 10. You don't need to know that, but it's nice to understand it. It inhibits the activation of those clotting factors, and it reduces blood coagulability. So these patients that have any issues with their clotting factors, warfarin would not be something we would want to give them. By the way, it takes 48 to 72 hours, 48 to 72 hours for warfarin to begin to take effect. But its maximum effect can be achieved several days later. So it requires very careful monitoring of the PT and INR to ensure therapeutic anticoagulation. It also can be affected by a lot of drugs and foods. So we would tell those patients to be very careful with their vitamin K containing foods such as kale, green leafy vegetables, broccoli, etc. It's okay for them to eat those, but they need to eat the same amount each week in order to maintain that. And again, they will stop those medications 7 to 10 days prior to a patient's surgery. Make sure you note that yes, warfarin will be stopped 7 to 10 days prior to the patient's surgery, or as the surgeon or cardiovascular surgeon directs. It takes a while to get these medications out of their system. Allergies. What happens with an allergy? If they are having multiple surgeries, they've had exposure to latex, then there is a high risk for allergies. So we want to make sure the patient knows to tell us if they have any problems with shellfish, if they have any problems with tropical oils or tropical fruits and vegetables and stuff, because some of those are related to the latex. Skin prep. What do we need to teach? Now, the surgeon may order for hair removal at the site prior to the surgicals, but they're going to ask it to be clipped rather than shaving. Because shaving sometimes makes small little cuts in the skin and decreases our skin's barrier to infection. So we want to make sure it's clipped with an electric razor instead of it being actually cut with a razor. In the operating room, an anesthetic solution to kill bacteria will be put on the skin. such as betadine or chlorhexidine, but we also need to make certain there's no allergies to those. Again, betadine is iodine. If they have shellfish allergies, such as lobster, shrimp, etc., then they cannot use betadine. Okay, incentive spirometry. That's an incentive spirometer of one type of them. It's a little different than the ones I've seen. But in order to keep this person from having pneumonia or atelectasis, we're going to tell them to do some deep breathing in order to move the mucus in their system. Okay, let me see here. My husband is calling, as you can hear. I'm trying to find a pause for this recording, but I can't find it. So let me see what I need to do. Okay, looks like he's no longer calling, so that's okay. To find that pause button. So excuse me while you hear me breathe around and saying, oh, let me see if I can pause. I don't know if I can pause or not. Nope, I can't pause without stopping the recording and transcribing, so we're not going to do that. You'll just have to figure it out, or you'll have to listen to me talk to him on the phone, one of the two. Okay, let's move on. What to teach for cardiovascular considerations. We're going to look for the risk for blood clots. We want to know if they've had previous blood clots, thrombosis, emboluses. Remember, a clot to the brain is a stroke, a clot to the heart is a heart attack, a clot to the lung is a pulmonary embolus. Any type of clot formation, it travels, we're at risk. Now, that could be either an embolus by air or fat. Remember, we talked about emboli or embolus, fat embolus with fractures. It can actually impair your breathing as well. We're going to reduce the chances of clot by early mobilization of this person. We're going to use TED hose. We're going to use SEDs. We're going to have them perform leg exercise. We're going to say, you know, do ankle pumps. Dangle on the side of the bed. Move your legs if you're capable of doing that. If they're bedridden and they're not able to move it, we're going to try to keep them as mobile as we possibly can. And again, make sure they wear the SCDs. I know that they're warm. Sometimes they're not comfortable, but they keep the person from having a deadly clot. Urinary considerations. So with the anesthetic, because it makes everything go to sleep, it's going to make the bladder tone also decrease and go to sleep. So they will need to urinate after 8 hours of having surgery. So monitor them for distension. Check their tummy. See if it's distended. See if they're uncomfortable. Once they urinate and can tolerate fluids, we're going to encourage to take adequate fluid intake. The Foley catheter is removed as soon as possible to prevent infection and promote urination. So monitor for I's and O's. Use a pain scale. Listen to the patient. I'm going to try to change out my sound device here. Let's see if I can do that because I'm being told that phones are about to go dead. So let me switch my sound. Always fun things that we have that happen. So I'm going to switch my speakers to my computer speakers. I hope you can still hear me. I'll check these. If not, we'll have to redo this. We'll, so again, we'll go ahead and switch over. Hopefully you're still hearing me because I'm not for sure my headphones are working any longer. We'll check that in a little bit. Okay, back to our I am recording on my phone. I am recording for my class, Dennis. That's why I'm not answering you. I'm sorry. I wanted to let you know about food. Okay. We want to use pain scale, what to teach with pain. We're going to listen to the patient. We're going to teach non-pharmacological techniques if possible. That would be using, imaging, try to get them through the pain control, set the goal. If they have a pain pump, such as pain control anesthetic, PCA pump, we're going to tell.
The button can be pressed, it's going to give them, but it's going to be set at certain parameters. They cannot overgive themselves. We're also going to use now they may have used during surgery other forms of anesthetic. They may have done nerve blocks. We need to know about that. They may have set up some other type of epidural type pain control. So you need to know, all about that. Need to know if that's been done. And again, you were going to use the pain scale. We're going to listen to the patient, but we're going to set realistic goals. If their pain medication is only every 4 to 6 hours, then and we're partially through that, we may need to stack medications, but we're going to have a pain plan. So uh, that will help the patient once they go home as well. We give Ansef or cefazolin or some type of antibiotic. Make sure you get these two drugs down. Don't get it confused with Reglan. Need to know what Reglan does, and there are questions about these, and you're going to get them confused. Everybody does sometimes. Ansef or cefazolin is an antibiotic. It is used to keep the patient from getting an infection. We give it to them before surgery. It's to treat bacterial infections. It reduces respiratory infections and urinary tract infections, skin infections, especially with bone, joint, and genital infections. They use other types of antibiotics as well to do these. We also do use Rocephin or ceftriaxone. It's a different kind of, it's a cefazolin. As antibiotic. Now, it has common side effects. Cefazolin or Rocephin can cause diarrhea, nausea, vomiting, a rash, and itching. It can also cause some pain or redness at the injection site if they get it IM, but usually it's given all IV. So, other tests that we're going to do during surgery is we're going to check their BUN and creatinine to make sure that they are their kidneys are functioning. So if we ask you a question, what blood tests do we do to test for kidney function? BUN and creatinine. We've talked about that in lab. It's one of those two tests that I had you highlight that says these are the tests that check for the kidneys. CBC tells us whether or not that if they're anemic, if they have problems with blood loss. The WBC, white blood cell alert. White blood cells tell us whether or not that patient has infection. And then we might do some liver function tests to make sure that their liver is in good shape and that they're going to be able to clear out those drugs. So very important for us to look at those. Um, with Rocephin, it's the same thing. We're going to look at the BUN and creatinine. We're going to look at their liver. We're going to look at their CBC and make sure that they don't have any allergies to cephalosporins or penicillins. We would give a different medication if that was the case. Initial postoperative care, we're going to promote their respiratory function. We're going to make sure that we watch for atelectasis, changes in lung sounds, make sure that they're doing deep breathing, watch for a cough that's productive, watch for fever, and make certain that they're turning, coughing, and deep breathing as they need to. We're going to also watch their vital signs. We're going to take vital signs as soon as they arrive, and then that's usually every 15 minutes for the first hour, and then 30 minutes is ordered, then once every shift. And we're going to compare that to the baseline. Has anything changed, or do we have any concerns? Then we're going to look at their surgical site dressing, make sure that the surgical site is clean and dry, that there's no excess bleeding, and then look at drains and tubes. Are we having a lot of draining coming out of that drain? Is the JP filling up too fast or the hemovac? Do I need to be concerned about bleeding that's going on? Is it too much bleeding? So we need to be assessing these items commonly throughout. We're going to do pain assessment, make sure the patient's pain level is under control, look at their fluid balance, notice their neurologic status, and then, of course, monitor them for safety and comfort. Make sure that we're positioning them and keeping their body and supporting their body in alignment and supporting their limbs. Make sure we have anti-embolism stockings on them or SCDs if they're not moving or they're immobile. Here's some pain medication control devices. We need to know the purpose of the pain control, the type of pain medications. Are they on opioids, non-opioids, adjuncts? Are they on PCA? Need to know if those medications, such as the non-opioid analgesics, like acetaminophen or an NSAIDs, I need to know exactly how much they've had, especially with Tylenol, so because we don't want to overgive. If they're taking multiple medications with Tylenol in it, I need to be adding those up. If the PCA pump is used, then we need to teach the patient how to use it. Then we also need to be able to set the dose amount and the lockout interval. Is it how much time is that patient going to be allowed to have between doses? What is the maximum dose? What is our responsibility for as a nurse? Is to monitor the pain level, make sure that we're using the correct pain medication based upon the assessment of PQRST to educate the patient and the family, explain how the PCA is actually used and to monitor the IV side, make sure that safety is our biggest concern, and ensure we have naloxone or Narcan available if we see respiratory depression. Again, that patient's respiratory rate is only 8 breaths or 6 breaths, we've got a problem. We've oversedated that patient. So we need to know that we need to put them on oxygen to set them up in high Fowlers. Go send someone for the Narcan, contact the doctor, and get further orders at that time. But make sure patient safety, remember your ABCs and your airway precautions, okay? If they're having nausea and vomiting, constipation, or itching, or anything, that we need to watch for those common side effects. If we have pain that is continuing even despite our best efforts, then we need to let the doctor know so that we can say, or if we're having signs of overdose or respiratory depression, again, treat that patient based upon what we're assessing. Surgical wounds, there's a number of different descriptions of our surgical wounds. We should notice whether or not the sutures are in alignment. Are the staples intact? Is the incision site good? We're going to be looking at the dressing as we take it off. We're going to note if they have serous, serosanguinous, sanguinous, or purulent dressing drainage. If they have serous is the clear watery. Serosanguinous is a combination of the clear along with blood. Sanguinous is bright red blood, recent or active bleeding, and then purulent is that thick yellowish green foul odor infected type drainage. So we have to watch for that. Make sure you're watching for redness, swelling, warmth, and of course, increased temperature of that patient. This patient may have JP drains. They may have hemovacs. We need to know, take a look at those, make sure, see if they're sutured in. A lot of times they may be sutured. Sometimes they're not sutured, so they're just taped in. You need to be careful not to pull those out. Watch how much fluid is coming into the drain and what you're emptying out. You need to measure that. That goes on the output. And then if you think that something is not correct or if there's too much blood coming out, make certain that you are contacting the doctor. Once you empty that, it should be compressed and then the stopper put back on so it's under suction again. We'll do that in lab. I want to make sure that you see that. Again, notice if the drainage in the JP is purulent, and if it smells, we know we have an infection. Some of these patients may have other tubes when they come out of surgery. They may have an NG tube that's going to their stomach to provide them medication or to keep the stomach collapsed. They need to know what to expect about that. We need to make sure that it's in place where it belongs. We'll learn more also about NG tubes and safety. when we do the NG in lab in a few weeks, and we'll talk more about that. But the gold standard of placement is a chest X-ray or abdominal X-ray to make sure that that tube is in the stomach where it belongs and not in the lungs. Hemovac, again, here's the Hemovac system. It's a pancake type drain, and it is used for the larger procedures like total knee, total hip. Don't tug on those, don't twist. Make sure that you empty and then collapse them again, and make sure that the cap is put back in place so that it continues to suck any of the drainage out of the wound site. Again, the doctor will come and discontinue that when he's ready for that to be removed. It is easy to remove those. There's very little discomfort. It might be a pulling or tugging, but it's not painful for those to be pulled out. We want to make sure that we're washing our hands before and after, that we're wearing gloves when we are emptying JPs as well as hemovacs, and we're using PPE. Okay, this is an example of a wound vac. If this person has a very large wound, it is actually a sponge type device that is put into the wound and has gentle suction in order to remove fluid and promote tissue growth. It reduces the swelling and it keeps the wound clean, and it may actually speed up healing. Again, a patient may also have a chest tube. This is the thoracostomy that goes in. They actually put this into the lung in order to drain out excess fluid that otherwise would keep the lung collapsed. You need to make sure that you don't pull on these lines, that we're still getting fluid, that they're in place. If you have a patient with a chest tube and they end up having shortness of breath, dyspnea, or difficulty breathing suddenly, and you notice that one side of the chest looks different than the other, that is an emergency. That may mean that the lung has actually collapsed, that the tube has displaced itself. Here's some chest tube basics. This is a drainage canister. It's all set up. It is put onto suction. It can hold up to 2,000 mLs of fluid. It is usually sutured in, but we need to make sure we keep it clean, that we keep the 4x4 pads on, use Vaseline gauze, that we keep it taped, and then that device should always be sitting upright. It can be on the floor, it can be hanging from the bed, but it needs to be upright. Don't let it fall over. It doesn't work well when it's falling over. As you can see, it does have a foot type rest that keeps it from falling. If it gets full, then that device needs to be replaced out. It needs another device set up and then continue on suction. Postoperative complications and prevention. So we have issues with respiration, cardiovascular, wound, gastrointestinal, genital urinal, pain, fluid, electrolyte imbalance, compartment syndrome, pressure issues, and adverse drug reactions. Know the meaning of these. I'm going to go ahead and pull my notes over so you can see those. But again, okay, here we go. Let's see if we can get this. Okay, I'm about there. This is a very long set of information here. There we go. Respiratory complications is collapsed lung, which is atelectasis, pneumonia, PE, hypoxia. I'm just going to let you read these down. There's cardiovascular complications, shock. You can actually pause this in order to get all this down or take a picture of this. Deep vein thrombosis, arrhythmias, wound complications, etc. I'm not going to read all of this to you because I'm giving it to you so you can see it. Evisceration, that's organs protruding through the wound. Dehiscence, that's where the wound edges separate and then tissue is coming up through it. Now, evisceration is further. If we have a stomach wound and we see that the intestines are now protruding through that incision, we need to put a wet saline, sterile saline gauze or sterile water gauze over that tissue and contact the doctor. So we want to keep that moist. Hematoma is that collection of blood under the skin, and of course, delayed healing. Here we have gastrointestinal complications. And then we have genital urinal complications, our pain control, pressure injuries, bed sores, and adverse drug reactions. And what signs do we report immediately? Here you go. Sudden shortness of breath or chest pain, excessive bleeding, severe pain not relieved by medication, signs of shock. So with signs of shock, they're going to have low blood pressure, rapid pulse. They're going to be cold and clammy, and they're not going to be talking to you very clearly. Okay, let me move this back out of the way. And we're going to go to the next slide. Postoperative pneumonia. That's due to prolonged mobility and bed rest. Shallow breathing instead of doing deep breathing and instead of spirometry, that's going to cause them to have pneumonia. They retain secretions, not coughing or deep breathing, is due to advanced age, chronic diseases, COPD, diabetes, smoking history, and impaired immune system. You're going to see that they may get confused. If it's an older adult, their signs and symptoms is fever, chills, productive cough, rapid breathing, which is tachypnea, chest pain or chest wall pain, crackles. You'll be able to hear crackles in the lungs. They'll have malaise, fatigue, and of course, tachycardia. With older adults, again, it's confusion. Uh, and they may be actually having a temperature of 96.6 or 96.8 with hypothermia instead of fever. So watch for low temperatures as well. So to prevent this, encourage that mobilization, encourage incentive spirometry. Don't let the patient say, oh yeah, I did it. Watch them do it. Make sure that they're doing deep breathing and coughing. I know sometimes with lung surgeries, it can hurt. So have them brace with a pillow, brace their stomach with a pillow. And if their complications are not managed, we're going to end up with respiratory failure, sepsis, and possibly death. If we, all of those will have prolonged hospitalization into them, but death is the worst that we could see. Okay, NCLEX practice questions. Which of the following is not a primary purpose of preoperative patient interview? Now, I'm going to pull again my questions over so that you can see these. So I want to make sure that you see the answers. I don't want you not to see the answers with these. I hate that. There we go. There you go. So the correct answer is D. There's the rationale. Determine the patient's postoperative living arrangements. Here's the next question. Which of the following is most accurate statement regarding surgical preparation? Surgical site should be marked with indelible ink by the surgeon would be awfully nice. Which of the following most accurately describes a major surgery? There is no time limit. A major surgery may only take an hour or even less. Sometimes they can take even more. Which of the following best describes the purpose of splinting an incision during deep breathing and coughing? It's basically to reduce pain. If anyone has ever had a C-section, you take that pillow and put it across your tummy while you're deep breathing, or if you have to cough, and that keeps everything braced so that you don't have as much pain. And the LPN review lab results on a patient on Coumadin therapy prior to administering the next dose. The INR was 6.5. What will be the next action by the nurse? Definitely hold that dose and call the doctor because we've already said that our goals are usually between 2 to 3 on the INR. This patient is too thin. We want to make certain that we hold that dose, call the doctor, and then get some directions on how long they need to hold the dose. We definitely want to probably repeat that INR the next day. The nurse is assessing surgical site on a post-op patient. The patient asks what signs and symptoms of infection to look for, what is the appropriate response by the nurse. And of course, you're going to get these type of questions all the time. Select all that apply. And as you can see, the answer is right here. I want to make sure you have the answer. Serous drainage is that clear drainage. It's normal. Purulent drainage, however, is abnormal. Which of the following is not a risk factor for postoperative pneumonia? So if we elevate the head of the bed, we actually take care of one of our risk factors. If we put them in the semi or high Fowlers, we've got the bed elevated. So that's the first thing we do when we see the patient is having difficulty breathing, get them sitting up high and then get them on at least 1 to 2 liters of oxygen until we can get direction from the doctor. Match the following postoperative care interventions with their primary purpose. So again, here's the answers to this. As you can see, as you read through, make sure that you match these, that you understand what early ambulation, incentive spirometry, neurovascular assessment, monitoring intake and output, and pain management is done to do. So incentive spirometry does uh, allow us to prevent atelectasis and pneumonia or collapse. So those are some good reviews right there. Here's the next one. Which of the following statements about herbal supplements and surgery is most accurate? Yes, your herbal supplements can increase the risk of bleeding during surgery. So we want to make sure that we know about what they are taking. Ginkgo biloba, St. John's wort, garlic, etc. Fish oil, that's the one that's not on here. Fish oil can definitely increase their bleeding. Which of the following is not a recommended practice for surgical pin site care? We did pin care in lab a little bit. We reviewed that, at least looked at the videos. We don't apply antibiotic ointment to all the pin sites. We want to keep it open to air and make certain that we're keeping it uh, clean so that they don't get infection. Which of the following is not a common clinical manifestation of suspected postoperative pneumonia? Severe abdominal pain, yes. Will have a productive cough. They will have fever and chills, and they will have difficulty breathing or dyspnea. They may have tachypnea, which is that rapid breathing. They may have crackles when we listen to their lungs. And of course, if we get an x-ray, we're going to see a whiteout of their lung tissue. Here's the NCLEX practice test. This is with a case study here. Which actions should the nurse take during the preoperative phase? Select all that apply. Have you take a look at this, make sure you understand, to make note of these, consider these, think about them. Which of the following patients are at risk for surgical complications? Select all that apply. Of course, that's going to be your youngest and your oldest. So let's see. Yes, your youngest patient is your 6-month-old. Let's see. Not that 25-year-old. He's healthy. 68-year-old with chronic disease, kidney disease, yes, indeedy. A 45-year-old with diabetes, they're autoimmune, and a 30-year-old with a history of substance abuse, yes. So the only one that's not true is that B. A nurse is caring for a postoperative patient who is drowsy, has a Foley catheter, and is receiving IV fluids. Place the following actions in order of priority. Well, it's already in the correct order. 1, 2, 3, 4, assess the airway, always airway first. Check the dressing, monitor for urine output, and review the plan of care for pain. Again, ABCs. Here's a case study with Mr. Cooper. Read through this and kind of look at the slide to the right. Make sure that you review this. Think about it, evaluate it, pretend that this is your patient that you're taking care of. And I'm going to take this down so you can see the other key considerations and goals. Okay, the next one. Oh, this one is very, very small. It's very hard to see. Let me see if I can give you a better view of this one. Person-centered care activities. Here's scenario A. Make sure you read through this, kind of look at it, to make sure you understand. These are the type of questions you're going to get on the NCLEX now. You're going to get a case study. You're going to get some selections. You're going to need to make a decision. You're going to have to use your critical thinking. Discuss these between you and your team of persons, your support persons. If you're in the classroom, I would have you guys kind of break out in groups and talk about how you would handle these. Are there any differences between your opinions and other nursing of the other students or nurses in your group? And then any questions. So this is the end. Don't hesitate to review this as often as you need. Make sure you get the concepts, get the ideas, look at it, make notes. If you have questions or concerns, get with me. And I thank you very much for spending the time with me and for letting me do this by remote. Again, make sure you have this down for your test when we do it in week 4. Thank you very much. Have a good night.